meet with you in the previous conference in Jeddah. We invite you, but I think we missed you during this event. It was 3 months back.
No, I never received any invitation.
Robert, it was sent actually, but I don't know if there was no reply.
No, I never received any invitation. Sorry for that, but I never received.
Maybe we have a wrong email or something.
Yeah, I think so. But you will see my email at the end of my presentation, the second of my presentation.
I will copy it. So
Dr. Roberto,
hopefully we'll see you next.
Dr. Roberto, you may start your presentation, please.
Also, because there is one of my fellow now in Riyadh.
She communicated with me, yes, I know. She's in Saudi Arabia. And she's,
exactly. Yeah. And
Dr. Roberto,
please let her
can you hear me?
Let them know that I'm really happy to collaborate. So no problem. Whenever you are. Okay. Sure. Thanks.
Dr. Roberto, you may start your presentation. You can share your screen.
Hello.
Yeah. You may start your presentation, please.
Okay, so I will start with my first presentation. And first of all, let me thank the kind organization for the invitation. I'm very sorry that I cannot be with you, but I am currently in Australia with another commitment. So the first presentation will be, it's a different one, so sorry. Sorry for that. No. Yeah, there is problem. Okay, I will start with this one and then I will let you know for the second one. So one presentation is about the mechanical complication after acute myocardial infarction, and particularly the ones characterized by cardiogenic shock and the use of Ecmo. So the question given to me was when to intervene and outcome. These are my disclosures. So first of all, I would like to give you an overview about.
We are not able to see your screen, Dr. Roberto. We are not able to see your presentation. So can you share it again?
So you're not seeing my, okay, sorry, again, let's see. Do you see now? Again? Can you see?
Yes, we can see now.
Okay, perfect. Okay, so I start again. This is about the mechanical complication after acute myocardial infarction. So these are my disclosure. So El-Badawi and colleagues recently released in the Journal of American College of Cardiology Cardiovascular Intervention a very important paper providing some information about the temporal trends and outcomes of mechanical complication. You can see here, for more than 9 million patients, divided in patients with acute myocardial infarction with ST elevation, you can see, and also non-STEMI. So the total population was more than 9 million patients, so really a huge patient cohort. And you can see the mechanical complication in STEMI patients were less than 0.3%, so really rare. And in non-STEMI, you can see here, in the STEMI patients, the papillary muscle rupture, which is the left rectangle, was 0.05, ventricular septal rupture was 0.21%, and femoral rupture was 0.01. So again, 0.27%, so very rare complication. But in non-STEMI, it was even more rare with 0.06%. And you can see again, also in this category, ventricular septal defect was the most frequent one, and the papillary muscle rupture and the free wall rupture of the left ventricle were even less frequent. So again, 9 million patients with acute myocardial infarction, the overall incidence was less than 0.3%, so rare complication. But still, you can see here the trend didn't change from 2003 to 2015. So there was no significant change of the occurrence of this complication. And if you look at the mortality of this patient, this is very important because in the complication occurring in STEMI patients, so with acute myocardial infarction with ST elevation, the mortality range from 35 to almost 60%. So this is really a dreadful, these are dreadful complications. Instead, in non-STEMI patients, the mortality, in hospital mortality, ranges from less than 10% to almost 30%. So still really important and really dreadful complication. So this is a very important contemporary review published in 2014, looking again of the trends in the treatment, not only in the epidemiology and the incidence of this complication. And this was very important because it shows that in ventricular septal defect, which is the most frequent of the three complications, if the intervention occurs within 7 days from diagnosis, the mortality can go from almost 40% to almost 90%. So this shows how really low the in-hospital survival can be if you are obliged to intervene very early. Instead, if you make the intervention going beyond 7 days from diagnosis, you can see that the survival is really much, much better in these patients. This was also shown by the STS, so the Society for Thoracic Surgeons, the American Society, and they look again for ventricular septal defect. If you intervene very early, let's say up to 7 days from diagnosis, the mortality can range again from 30 to more than 70%. Again, underlying how really bad the prognosis can be if the patients are operated for ventricular septal post-acute myocardial infarction ventricular septal defect very early, so within 7 days. So there was this proposal to treat this patient. So the question to me was when to intervene and when to use Ecmo. You can see here, if you have an hemodynamically unstable patient, you can decide to go immediately to surgery, but this, as I showed you, is related and associated with very bad outcome, with almost in-hospital mortality ranging from 40 to 90%. So in this situation, maybe Ecmo should be used and the surgery should be delayed, as shown here. Instead, if you have hemodynamically stable patient, but with a large ventricular septal rupture, then you can still use some conservative treatment, but I think the best way would be to implant intra-aortic balloon pump or Ecmo, and then still be trying to delay surgery after 1 week from the diagnosis. And finally, if you have hemodynamically stable patient with small ventricular septal rupture, well, this is the most favorable category of patients, so the delay usually is possible. You can even try to use conservative management or even percutaneous closure, and therefore you can delay elective surgery. This was our study using the ELSO registry. We looked at the use of Ecmo in the setting of post-infarction mechanical complication. And we had almost 160 patients. And you can see that the results in this setting were not really favorable. You can see here Ecmo withdrawal for expected recovery was a little bit higher than 55%, but the survival to hospital discharge was less than 40%. So again, I would like to underline, so that successful weaning was achieved in almost 56%, so 56%, but the hospital discharge was a little bit higher than 37%. So almost 20% of these patients died after successful ECMO weaning. And indeed, if you look at the type of patient, again, 158, the complications during the support are really major. And you can see, I will talk later about sepsis and vasoplegia, but what is more important, you have neurological, so more than 13%, hemorrhagic complication, more than 32% of the patient. So I think this is very important to underline that these patients are at risk even after successful ECMO weaning. And you can see here, this is a percutaneous closure of ventricular septal rupture. These are just a few, very few cases used and published to allow the patient either to arrive at the surgery a little bit delayed, so not in immediate surgery, or even trying to have a final and complete treatment of the ventricular septal rupture. So this treatment is getting more and more applied. So in the future, I think we will see more percutaneous, at least attempt to close the ventricular septal rupture after myocardial infarction. And you can see here that this paper from Rob and the Professor Belolavec from Prague, they also advised the early use of ECMO. And you can see here in their very limited series, only 7, but you can see clearly that after ECMO implantation, still without surgical intervention, that all the parameters like mean arterial pressure, heart rate, lactate, and pH, they all improved after the implant of ECMO. And you can see here the difference between the outcome of patient in shock without ECMO, shock with ECMO, and the patient non-in shock, so operated. You can see that if you use ECMO in patient very unstable or in shock, you can go towards the non-shock patient. So ECMO can improve the outcome of this patient at the end treated surgically. So again, you can see complication in ECMO and non-ECMO patient. Obviously, bleeding was more frequent in ECMO patient, and you can have, unfortunately, fatal bleeding in this patient. And not obviously, infection was also more important in ECMO patient. And all these complications we know are frequent in ECMO patients. But again, they provided some algorithm, which is almost the same as what I showed you before regarding the treatment of hemodynamically stable, unstable, or patient in shock. This is another paper about the delayed surgery in ventricular septal rupture. And again, this shows the importance of the delayed surgery. So the emergent surgery has very low prognosis, whereas the delayed surgery is absolutely more favorable. And to delay surgery, ECMO is very important. And you can see here, as soon as ECMO was implanted, you can see at the operation day, so pre-support and after the implant of ECMO, all the liver enzyme, all the creatinine, CK-MB, and troponin, all the parameters improve. This, again, showing that the use of ECMO could improve the patient condition and the status at operation. This is a very important paper published by Watkins and colleagues. Again, very limited series in the Annals of Thoracic Surgery in 2018. And you can see 12 patients only, all operated in a cardiogenic, actually, so they were all in cardiogenic shock. And the authors put the patient on ECMO to improve their hemodynamic and metabolic condition. And you can see here that there was one patient who died on ECMO, but the rest, you can see here, they improved significantly from pre-ECMO to post-ECMO. So all the parameters as shown before improved significantly, and all patients arrived at surgery in a much better hemodynamic and clinical condition. And you can see here, these two patients were with a ventricular septal rupture, and they were treated with the Ecmo prophylactically. And you can see there were, of course, complications as shown also before, but if we look at the in-hospital mortality, there was 0. And 30 days, no patient died. So only 2 patients died at 1 year. Again, underlying that the prophylactic ECMO in this post-myocardial infarction complication was really helpful to improve their status and improve the surgical outcome. We recently published a sort of review paper in the JACC and cardiovascular intervention because we think that the use of ECMO or mechanical circular support in patients with post-infarction ventricular septal rupture is very important, but you must consider many, many issues. And you can see here, I don't want you to go in, to read in details, but what I want to underline is that each mechanical circular support may change the pathophysiology of ventricular septal rupture. You have a shunt between the right and left ventricular chambers, and whenever you use a mechanical circular support system, you may change this shunt, and you may either increase or decrease and even convert the shunt from left to right to left. And this, of course, can also deteriorate the patient status. So you must be really careful, monitor carefully the patient, and know what is the consequence of your mechanical circular support. Indeed, as shown here by Iraoka and colleague, they use the Impella after the ECMO positioning, and what they had is an unexpected right to left shunt, and this deteriorated significantly the patient's status instead of improving it. So this should be taken into consideration each time, as you can see here. And indeed, we propose some algorithms. Again, if you want, you can have a look at the papers, just using the EABP and optimal medical therapy, but you have also to use MCS, particularly knowing each system, which kind of consequence has on the pathophysiology of this complication, as you can see here. So each time the use of, for instance, of combined MCS like intra-aortic balloon pump plus the ECMO or Impella or other kind of devices should be always considered in the light of the change on the pathophysiology. So I think now we are proposing a new study, as you can see here. We are going to make we made a survey in all these centers in Europe, trying to understand what kind of approach all these centers have. And you can see here, the majority try to stabilize the patient condition. And when is the timing to intervene in this patient? As you can see, the majority tries to go towards 10 or 7 or 5 days. This is the majority. And also, again, this is very important, what kind of approach, and you can see the majority, again, try to use MCS to unload the left ventricle. And finally, you can see here what kind of mechanical circular support. The vast majority of these centers use veno-arterial ECMO, and the second MCS is intra-aortic balloon pump, and the last is Impella. So you can see all these survey, the questions were answered in this way. You can see again about the combination of devices, the way to treat this patient, and what kind of approach, like percutaneous or surgical. And why did we do this survey within this large center cohort? Because we want to propose a new control randomized trial in these patients, which will be multi-center, international, and prospective, obviously. We will try to enroll more than 250 patients with 5 arms, so control and all the other MCS, all the combinations. We will try to follow up these patients up to 6 months, and we will have composite endpoints with primary and secondary endpoints, because we hope to show that the use of prophylactic mechanical circular support, particularly veno-arterial ECMO, in this patient will improve the hospital outcome, which is now still higher than the mortality is higher than 50%. So whoever is interested, please contact me. I will be the principal investigator of this study, and I will be really glad to involve also your center. So in conclusion, I think that the post-acute myocardial infarction mechanical complication remain a very, very complex situation and challenge to manage and treat. Obviously, still the surgical treatment is the first choice, but for ventricular septal defect, the delayed surgery is the best. For papillary muscle rupture and free wall rupture, obviously immediate surgery still represent the best choice. The percutaneous treatment is advancing, but the hemodynamic stabilization before surgery, particularly in ventricular septal defect, would be advisable, although its effects are not yet proved. And Ecmo is shown to be promising, improving or stabilizing the patient hemodynamic conditions, and therefore enhancing a better surgical repair and in-hospital survival, but we need more investigation. And finally, we hope with this prospective control randomized trial, which will be called PROF-MCS DSR, will be able to show that the use of ECMO prophylactically will improve the patient outcome in this very challenging setting. I thank you for your attention.
Thank you, Dr. Roberto, for the excellent presentation. Now we move the second presentation by you, managing vasoplegia after successful VA ECMO. So can we continue?
Yeah.
Are you ready?
Yes. Yeah. Let me open because I don't understand why, and it opens always the same presentation. Can I connect a little bit later because I don't know why it's not opening the other presentation.
Okay, it's okay. No problem.
Maybe if we have some question regarding this one, and then I will try to reconnect after the other presentation.
Yeah, just wanted one question to ask you one question. What criteria you follow means how you choose that whether we should go for ECMO or Impella support when you come across with these VSRs?
Yeah, that's a very important question. I would say that Impella is showing more and more to be effective in this patient, in particular in a patient with ventricular septal rupture. I think that if you use Impella in a free wall rupture could be a problem. And with papillary muscle rupture, it's been shown also to be effective, but I think the risk of having maybe a papillary muscle sucked into the pump would be really high. For ventricular septal defect, again, there was previously considered a risk to have maybe debris from the ventricular septum to be sucked into the Impella device. But many case reports or case series have shown that this is not the case. So now also Impella is considered an effective treatment or stabilization device or hemodynamical improvement for the patient. And therefore, I think both can be considered effective, both of them. So ECMO and Impella. I think intraortic balloon pump is giving also a good support, but not as much as ECMO and Impella. So in case you have a very severe refractory cardiogenic shock, I think Impella or ECMO are the best treatment. To be honest, I think that being a ventricular septal rupture, a disease in which also the pulmonary system is engaged, I think that veno arterial ECMO would be better to guarantee also gas exchange. But again, if you have an isolated left ventricular problem, like after myocardial infarction, maybe Impella can work. But again, as I showed, Impella sucking the blood from the left ventricle, sometimes if you are going too far or too high with the suction, you can really make a conversion of the shunt from left to right to left. So you have to monitor very carefully what happens once you implant each device, because also ECMO, if you implant the arterial ECMO, you increase the vascular resistances and you increase sort of the afterload. And therefore, the shunt left to right can be increased. Actually, usually it increases. So you have to be careful each time you use a device to monitor immediately which consequences you have each time you use a different device. So Impella and Ecmo can be used, I think, for any issue. I would prefer being arterial Ecmo, but Impella is coming also very much used in this setting.
Thank you very much. So you can be ready with your next lecture. By that time, we'll finish the next session here.
Yeah, exactly. And then I will reconnect. And please send me another link because this one I see
is
expiring.
No, it will not expire. Don't worry, it will continue.
Okay. Okay, so I can access. Okay, so I will wait for the other lecture and then I reconnect. Okay.
Continuing with the session, we have our next speaker, Dr. Jan, will be talking about tips for successful VA ECMO. And Sir is President Member of Steering Committee Euro ELSO 2019 to 2022, former member of Association of Heart Failure Committee Euro ELSO 2018 Conference President and co-author of US patent hemodynamic monitoring devices and a PI of many research, several research grants. Over to you, sir.
My talk is pre-recorded, so if you can let the talk to go live, or if you don't have a talk, I can go live if you like.
We don't have your talk at the moment because it was probably the same talk was sent to us. So can you share the screen and you can deliver the talk?
Okay, no problem.
Thank you.
I can do that. So just let me share the screen. I'll do that, but I'll send it twice actually. Okay, it was confirmed. No problem. Okay, so can you see my screen?
Yes, sir, your slides are visible.
Okay, perfect. So thank you again for inviting me for your conference and the talk. My topic for today is tips for successful VA ECMO, and I will stick with ECPR as I talked yesterday, and I'll give you some hints on how to perform well in a system where you could use ECPR or very early emergency ECMO. This is my disclosures, and I'll go through logistic challenges, kind of a complex care, also complications, and I'll touch a little bit of attenuations. So let's start with the logistic challenges. It's always about the time, and if you talk about emergency ECMO, either it's cardiogenic shock or ECPR setting, you always have to have a plan, and the team has to be ready for performing well. So this is our plan. Actually, we had in 2012 when we designed the ECPR trial, and have a look what happened at that time. So we decided that we should have a crew on site for cardiac arrest within 10 minutes, then 10 minutes to decide, then 20 minutes to transport, and then 20 minutes for ECMO attenuation. So our target was 60 minutes. So what actually happened in the real study, which has been about 10 years later published, it was completely different, actually. We did have our crew about 8 minutes after cardiac arrest on site. Then there was about 15 minutes decision time, so longer than we expected. So we have been deciding after 20 to 25 minutes, and then the transport was about 25 minutes again. So we were somewhere around 15 minutes where we started ECLS cannulation, but we due to training, we decreased the time for cannulation, which was between 10 and 12 minutes in last year. So we actually our target of 60 minutes was reached, and we reached this target to 61 minutes of the study. So this is just to demonstrate that for a very emergency situation, which are consistent with no flow, low flow, and then sometimes unstable ROSC and emergency ECLS cannulation, you have to count pretty well. And you have to be sure that you are reaching your target, because if you don't, you may end up with a unfunctioning or poorly functioning ECLS. And this is important, the overall organization of the team in hospital. I'm talking about the team availability 24/7 because it's only several specialists and high volume operators who are involved. And we also know that the off hours ECPR is not routinely covered, and it's much worse, has a much worse outcome. The other thing is that probably there is a limited number of beds available in every institution. In our institution, we only have two ECPR beds available at the same time, so it's very difficult for us if we have two patients to admit another one. And also, it's not just about the doctors, it's about the team and the nursing staff, and this is all very demanding for nursing staff. The other point is the training of the team. You know, we are talking a lot nowadays about simulation trainings. We actually trained and simulated the ECPR process for 2 years before we started the randomized trial. And this is not easy because the real patient comes usually one per week or one to 14 days, and it's somewhere around 5% of all out of hospital cardiac arrest cases. So there is not much time for training and practicing in real patients. So simulation training is the mainstay of preparing the team. And the other thing is very thoughtful and detailed communication with EMS. Because the EMS sometimes they perform conventional CPR too long before they realize that they should actually call to the center to prepare for the plan B. And if we try sometimes to call them and to say that there's a problem, they reply that it's too much work, and later they don't want to talk to us. So that's a little bit of problem because we are losing the time. And they are also biased with the proceeding with invasive approach because they deem that this is much, much better all the time. And it's not true for all subgroups of the patients. The other point is when you admit a patient for eventual ECLS emergency implantation, you have a very short time to decide whether the patient is or is not a candidate, and it's usually 30 to 60 seconds, and there is no marker to use. So we don't wait for any labs or any other physiological markers to be sure that the patient is a perfect candidate, because if you don't wait too much, you lose your time to get on ECLS properly and swiftly. And there is only signs of life which help well. So in any patient that shows the signs of life, CPR is always a candidate for cannulation. And the last question, which is sometimes very difficult to answer in institution, who should cannulate and where it should be cannulated? Currently at our institution, we have trained 4 persons. We preferably cannulate at the cath lab, but if it doesn't work, we can do it also in ICU or the emergency room. Concerning complex care for multiple organ dysfunction syndrome, everybody has to be aware that by the accumulation of emergency ECMO, the story only starts, and it usually follows by the development of multiple organ dysfunction syndrome. This is a young lady who has been resuscitated for 51 minutes, was put on ECPR, and she did quite well first 24 hours, and you see she was extubated to full consciousness. However, she developed respiratory failure. She has to be put on a non-invasive ventilation and later on re-intubated. And she had undergone a very severe multiple organ failure syndrome. You see the complex care right over here involving all available methods at that time and a very prolonged post-CPR and post-critical care follow-up. You see, she had a tracheostomy and she was weaned for a long time. So when starting an emergency program and using ECMO for emergency patients, of course, the other task is to evolve and to develop a very thorough post ECMO follow-up, including outpatient clinics. When the patient is being discharged home, we do have a specialized outpatient clinic, which is within the heart failure clinic, where we care for all patients who are post-ECMO to be sure that any possible complication, whatever it is, and it's in cardiac arrest cases, it's usually some mild or moderate neurological injury, post-CPR myopathy, neuropathy, and the social reconnection. This is all important, including nutritional support and things like that. So this is important that the institution which is providing ECMO is also providing a complex care after a successful ECMO. Otherwise, if you let those patients go to the regional hospitals, we had a lot of those who died actually a couple of weeks later because the care was not appropriate for those patients. And inevitably, in ECMO, you have a lot of complications. The major complication will be the bleeding. Basically, everybody on ECMO is bleeding. And in the most advanced patients, like cardiogenic shock or ECPR, there's a more than 30% chance of having a severe bleeding complication. So this is a typical patient post-prolonged CPR. You can see nicely he has been resuscitated for a long time. He developed acute disseminated intravascular coagulopathy, bleeding from everywhere. You see bleeding from his nose, from the mouth, bleeding from all the invasive cannulas. Yeah, so this is a very typical, and also the institution, the ICU, the complement, the laboratory, blood bank, everybody around has to be prepared for solving those complications. This is a lady who has been resuscitated for about 60 minutes. She had a severe lung bleeding and she had occluded trachea with blood. So you see she's on full ECMO and she's not ventilated. This is just a TPs and she didn't have any tidal volume. So this is rare occasions where we have to be prepared to solve problems we have never met before. Then there's other things we have to talk about, which are not so often discussed, like short gut syndrome and severe hypovolemia. So this is one of our neonates who have been after a very difficult delivery put on VA ECMO, as you can see over here, with a severe capillary leak syndrome and edema. And again, even in such a young children, you can see the fully developed multiple organ failure, which needs to be treated properly. And this is another typical complication, which is very bad for nursing staff. This is severe gut shock syndrome with severe diarrhea, severe volume dependency, and hypovolemia, which is quite often in patients post prolonged cardiac arrest. And all the team has to be used to that and has to be prepared to solve such complications to maintain patients alive. And this is very demanding in the initial phase. So in the initial phase in those patients, our nurse to patient ratio is usually 2 to 1, sometimes even more, because those patients are very demanding in the first 6 to 8 hours. And the lack of pulsatility is another very typical occurrence in severe cardiogenic shock and cardiac arrest patients. So you can see a typical tracing in a patient who has been with a severe left ventricular dysfunction put on VA ECMO. This is not an artifact, this is 90/90, so this is a non-pulsatile flow here again, and this can be very dynamic, minute to minute, can be changed, and this is of course something we don't want to have, and therefore has to be solved properly by LV venting or whatever kind of venting strategy is used in your department. We usually use a ECPLA approach. There is a strong rationale to do that because it's the most effective way to unload the left ventricle, but it's also the most expensive way to unload the ventricle. You can also increase the total cardiac output by using a combination of Impala and VA ECMO. And by that, you are minimizing the demand and maximizing the supply of oxygen, of course. And you have seen previously yesterday those PD curves nicely showing that by combining those two devices, you can unload or vent the left ventricle and decrease the stress on the left ventricle wall. Current evidence for the use of ECPLA is kind of mixed. There is a lot of non-randomized studies. There is no randomized study to date showing the benefit. However, the most appropriate study is this study by Schragi and colleagues from Hamburg. They have shown in the matched population of VA ECMO and patients on ECMO that early ECMO is probably better for those patients, and the probability of any death was lower in those patients who were put shortly after ECMO implantation on combined Impala Plus plus ECMO. However, this is based everything on just observational studies, which suggest benefit. However, there's a selection bias, kind of causality limitation, limited sample sizes. And there's also different treatments in the control group of those studies. So there's ECMO with or without balloon pumping. Some of those patients were surgically vented. So this is a very heterogeneous population. So we cannot say definitely what's better, but still there is definitely patients who need venting, and this is patients with a left ventricular thrombosis or risk of left ventricular thrombosis, and also patients with severe pulmonary edema due to left ventricular overload. Let's go to difficult cannulation. Emergency cannulation, whether it's in the cath lab or emergency room or whatever, is always a teamwork, and it has to be very effective. So there's no place for improvisation. This has to be trained. This has to be orchestrated. Everybody has to have assigned roles. The cannulator, the intensivist, perfusionist, and the cath lab or ICU nurses, they need to know their roles during the emergency cannulation. For the cannulation itself, we always use a guided approach. So we always assure to insert cannula into the proper vessels. So first it's ultrasound or X-ray guided, the cannulation itself, and then we cannulate under X-ray or under ultrasound guidance to be sure that the cannula is inserted into the proper vessel, which is not easy sometimes to recognize. And of course, we have to be very careful with proper cannula attachment, mainly in the arterial part, and then the distal perfusion cannula at the end of the procedure, at least in our institution, is basically almost always implanted immediately. We are not waiting for the signs of ischemia. This is how the cannulation goes down. So this is cannulation under X-ray. So you can be sure that your wire, this is the wire in the inferior vena cava, this is the wire in the aorta. So by just X-ray, can be sure that your wires are in proper vessels. We have skipped the blind cannulation. We use ultrasound guided punctures, X-ray guided insertion, and we always put in the sheet and perform angiography if there is a time to do that, because then you can estimate the cannula use and also actually to properly insert the cannula. We use a stiff wires, and if you use a stiff wire and a proper preparation, you don't need to dilate before the insertion of the cannula to save the time. So I'm again stressing that it's always necessary to have a live X-ray cannula insertion control, or if you don't have it, you have to be sure that your wire at all times is always freely movable to avoid kinking, because if you get a kinked wire, that's a disaster for emergency cannulation. But this is some videos from emergency cannulation. This is an easy one. You see this is the injection into the vein, which is nice, and the injection into the femoral artery, which is also nice, so very easy emergency cannulation under CPR. This is a little more demanding. You see this is the vein. You can see two sheets inserted into the vein, so it was not easy. So the two sheets were inserted, and finally the sheet was implanted into the femoral artery. But you see right over here, the sheet, the 6-frame sheet, is actually the same size as the femoral artery. So you cannot put in the ECMO cannula in such a tiny artery, and this is not seen otherwise. So you see how beneficial the X-ray can be. So we had to convert to the left side, and if you look to the left side, the artery was much better, and so the patient was cannulated from the left side. This is a typical picture for women where the arteries are sometimes very tiny and difficult to get in. This is another complicated cannulation. You see, this was a vein. This was an emergency cannulation during cardiac arrest on the ICU, and then the arterial cannula quite far away, cannulated here from the vein, but it was again implanted into the vein. The patient had a severe pulmonary arterial hypertension and severe dilatation of his inferior vena cava. So after that, the third cannula has been implanted to the artery. So we had to clamp this cannula and at the later stage to attach it by the white piece and use both those cannulas for suctioning and the other cannula for the arterial return. This patient survived well and was later discharged with a treatment of pulmonary arterial hypertension. So let me conclude from this very short overview of possible complication challenges and tips for successful emergency via ECMO, that it's for whatever reason it's needed, it's always challenging, needs an orchestrated and trained team, needs a lot of experience, possibly high volume, dedicated personnel, a lot of training, and of course adequate setting and supplies. Whatever it is, whether it's cath lab, emergency room, ICU, the team simply has to be trained. Thank you very much for your attention.
Thank you, John, for a wonderful presentation. So I have one question. How frequently you come across out of hospital cardiac arrest management, and you put the patient on ECMO, and later we came across that patient has a neurological insult, significant. So how frequently you come across, and how do you manage this? To the family, how you approach, and what your losses are, how you do?
Yeah, we are a high volume cardiac arrest center. So in our center, we see about 150 cardiac arrest cases per year. So it's quite a lot. And concerning the refractory cases suitable for VA ECMO, for ECPR, it's about 50 cases per year. So it's about one case per week. So that's the percentage. So it's quite a lot actually. Because those patients spend at the unit at least plus minus 5 to 9 days. So you can imagine that there is always at least one patient who is post cardiopulmonary resuscitation. And concerning families, and what you have been asking is that, of course, immediately we talk with the families about all the aspects of this, which is very complex. I don't want to. I just tell me what kind of details you want to hear, and I can go into the detail if you like.
Thank you for excellent presentation. I have one question. What is your door to VA ECMO type?
Yeah. This is the most important part. Yes, we are lucky that yeah, actually the time or the distance from the emergency car, which is bringing the patient to the cath lab, is very short. So it takes about 30 seconds, 45 seconds to get from the car to the cath lab, just next to the door, and that's a great advantage for us. And then we count the door to ECLS time. And as I said in the study, over past 8 years, the average time was 12 minutes. But honestly, it's much shorter. Usually we are done without 7 to 8 minutes. And there's of course some outliers in this. Sometimes you get a problem with the femoral arteries which are occluded or something like that. So I would say in 80% of patients we are done within 10 minutes. And then there's 20% of patients where some problem, and then it takes longer time. We had a couple of patients who had to switch to the axillary approach, so it's good to train also the axillary approach to be useful for the emergency setting.
Thank you for sharing your knowledge and experience. And we move on to the next talk.
The next talk will be from Dr. Roberto again, managing vasoplasia after successful VA ECMO. Okay, Dr. Roberto, can you listen to us?
I'm here. Sorry, I'm trying to share the screen. Can you see the screen?
Yes, sir, it's visible.
Okay, again, thank you very much indeed for the kind invitation. Very sorry that I cannot be with you in India, such a beautiful country. So these are my disclosure, again, not really different from before. So this is a very important paper about vasoplegic shock by Landry and Oliver. This was published in 2001 in New England Journal of Medicine. And as you can see here in the table, the causes of vasodilatory shock. This is a very important paper, and I would really suggest and advise you to read it if you do not know, because this is really such a clear paper about all the mechanisms underlying a vasoplegic shock. You can see in blue, these are the mechanisms underlying the vasoconstriction, and in red, the mechanisms related to vasodilation. We know that unfortunately, sometimes these mechanisms are absolutely impaired in the patient in shock, and actually the shock could be really in a spiral way going to a refractory state And this is mainly due to, as you can see, for an increase in nitric oxide synthetase, and this is going to increase the phosphorylation of myosin of the vessel, but also the reduction of ATP and the pH increase, and also the increase in lactate has another very important effect on vascular smooth muscle cells, again towards phosphorylation of myosin. And finally, there is an increased secretion of vasopressin, which in turn decreases the storage in the stores of vasopressin, reducing the extent and the entity of plasma vasopressin. And all these factors contribute to the refractory state of vasodilation. What I wanted to take, and actually I mentioned already in the previous talk, is that there is quite a very important extent of patient undergoing extracorporeal membrane oxygenation, and particularly veno arterial. And we made an investigation, a review article looking about the cause of death and the timing of death. And we made an extensive review, and what we found is that the survival, sorry for the misjudging, 44%. The mortality in hospital, 56 in veno arterial, but on Ecmo is only 38%, and after Ecmo is 18%. So a lot of these patients develop refractory vasoplegia, and sometimes we remove Ecmo and they still develop a refractory vasodilated shock and septic at the end. This was also underlined in another important study we just published in the Lancet Respiratory Medicine. This is a VV Ecmo, mainly VV Ecmo, but again, if you look at this 1,000 and more, the in-hospital death was almost 50%. But again, death on ECMO was 81, and death after successful ECMO weaning was almost 20%. And you can see that sepsis was the main cause of death of this patient. So this was also underlined by the group from Paris, by Daniel, just published in the Journal American College of Cardiology in more than 1,200 patients. They look at the hospital survival of this patient, and you can see here that in case of use of ECMO, veno arterial ECMO, for refractory vasoplegic shock, the in-hospital survival was very good, 96.2%. But look at the 5-year mortality of this patient, really low, a little bit higher than 11%. And this was the worst group of all the other etiologies for which veno arterial ECMO was indicated. And if you look at the patient who were in veno arterial ECMO under or not under cardiopulmonary resuscitation, as you can see, and you can clearly see again that the group for refractory vasoplegic shock was the worst, with only 24.3% without cardiopulmonary resuscitation, and only 11% with or patient under CPR. And also, you can see that the refractory vasoplegic shock was the worst, again, in terms of association between the etiology and the patient survival. And you can see here, there were only 9 patients, so again, quite a rare complication in this patient, but you can see limb ischemia, general bleeding or neurological complication, and brain death or renal failure were the cause of death in this patient, the complication patients. This is a very interesting paper by Ortoleva and colleagues from the Boston, the Mass General, about the use of methylene blue for vasoplegia occurrence in veno arterial ECMO. And these were the indication for ECMO implant. You can see here, there are also VV ECMO, as I showed you before in our paper from the COVID-19 patients. And this is a very interesting paper because they showed us that in any patient who had at least a 5% increase in mean arterial pressure after the introduction or administration of methylene blue, this was absolutely a predictor of survival. Instead, if this was not observed, mortality. So the response under Ecmo for a vasoplegia occurrence and the use of methylene blue, if you do not have an increase of more than 5% of mean arterial pressure, these patients are almost going to be dead in hospital. This is another important paper from Zotman and colleagues. They look at the different use of a vasoconstrictor or inotrope or vasodilator in their series. And you can see in more than 230 patients that in almost 30% they were forced to epinephrine in this patient due to refractory vasoplegia. But it's very important to show the difference between these three groups. So no inotropes like dobutamine or levosimendan, or the use of epinephrine. And you can see, in this slide, that the group with the use of epinephrine due to vasoplegia had the worst survival in hospital survival. And if you look again at the incidence of the catecholamine dose with the use of epinephrine, you can see again there was a significant difference between these two groups in hospital mortality. And about the forest plot, you can see that the presence of epinephrine was always a negative predictor. You can see here, and the same for propensity match group. The epinephrine was again confirmed as the predictor of in-hospital mortality. This is also a very interesting aspect of vasoplegia in venous arterial ECMO. We all know that hemo absorption has been suggested as a potential therapy in this case. And this is the first publication about the use of cytokine removal, so cytosol, in patients undergoing venous arterial ECMO. And you can see here the venous arterial ECMO, and therefore the epinephrine dose increase, then the use of CVA for the use of cytosol, which allow the reduction of all vasoconstrictors. And you can see that here again the introduction of cytosol make a reduction of the interleukin 6, again confirming the reduction of the inflammatory state in these patients. Another very important issue is, what about the high flow ECMO in patients with refractory, again, vasoplegia in terms of hyperdynamic septic shock? This was, again, a case report, and you can see that due to a progressive hyperdynamic septic shock and due to the very high cardiac output requirement, this was not possible to be maintained with vascular resistance. So, due to the hemodynamic septic shock, due to a bilateral staphylococcal pneumonia, the author performed obviously a femoral venous ECMO. This was not enough, and due to the fact that the flow, the requirement was more than 14 liters, they used a second venous arterial ECMO in the jural axillary configuration, and this patient was saved. Otherwise, you can say that this can always be a successful option, and this was shown by the group from Muhlenbach, by Credel and colleagues, and again, a double peripheral venous arterial ECMO. In this patient, you can see the requirement about high flow ECMO was achieved by a double groin cannulation. And you can see that they also use a transseptal cannula position to unload the left ventricle. But despite the double ECMO, despite the left ventricle unloading, unfortunately, this patient eventually died. Again, confirming that the high flow ECMO cannot be just a panacea for all patients with refractory vasoplegia. Steroids in ECMO has been also used, particularly in patients in venous extracorporeal, and they show to be sometimes also effective in the presence of refractory vasoplegia. But unfortunately, the data and the evidences in this respect are very low. So I think that, again, I I can conclude that the vasopressin incidence in binoarterial echo remains rather unknown. So in some evidences, you have a quite a high incidence of even reaching 30% of the patient. In other studies, you have a little bit higher than 5%. But most of the time, this vasoplegia is related to sepsis or to fluid overload. There's still a high mortality rate. There are limited options. And I think vasopressin is apparently the best treatment, and I will say the first line. And the epinephrine is expected to have a bad outcome, unfortunately. Methylene blue is considered a second line treatment, but still controversies remain. I think absorption is promising, but again, also here, we know that there have been controversial results, even showing that absorption can have a negative influence on in-hospital patient outcome. High flow is possible, like a double binoarterial echo, but the results cannot be always favorable, unfortunately. So we need to study new therapies and also to have more investigation in this setting to understand better the underlying mechanism and particularly the interplay between vasoplegia, refractory vasoplegia, and extracorporeal life support, which is still, I would say, not completely and fully disclosed. Thank you for your attention.
I have one question for you. Do you have any experience with vitamin C, thiamine, or cobalamin?
Well, personally, not. I have no experience, but I heard that there are also very controversial attitude and evidences about that. I think that this field requires extensive investigation, and I think that we should really be able to join our efforts and understand more and more what is actually and today not completely understood, which is again the interplay between the extracorporeal support system and the effect on a vasoplegic state. We know again we have some understanding of the underlying mechanism, but the interplay of these two situations are still completely unknown, and therefore there are only attempts. I would say, sometimes you have some favorable outcome, but no conclusive and really well-proven evidences. So I think we should do, and we should go back to the lab, to maybe preclinical investigation to understand more. And we are going to do that. We are going to submit quite a large research project to the European community to be supported and funded about exactly this, the combination of extracorporeal life support and induced vasoplegia or refractory vasodilatation. I think we need to study more and more this aspect because we have really poor understanding.
Thank you. I have another question. How frequently you do this double
Please.
vessel cannulation? That's one. And second, do you prefer to do central cannulation by sternotomy if we are not able to achieve that flow which is required?
Okay, so a recent publication from the Ecmo group showed in septic shock patient rather favorable outcome. And Graham and McLaren in Singapore advised of send Ecmo in the Catholic population. Or let's say both evidences have been quite successful. To be honest, septic patient could be, of course, an option, but I think we have no conclusive evidences that this is exactly the best configuration for this patient. Obviously, again, in septic shock, you need very high flow, so a central cannulation should provide a higher flow in ECMO. Now, saying that central cannulation is better than a bilateral or bifemoral ECMO, so double ECMO. Of course, double ECMO could double the complication because you have, of course, two limbs cannulated, so you have to be careful about limb ischemia. But the vascular resistance or the afterload of the heart could be also doubled. But usually the problem is, do you have a distributive shock or you have a myocarditis-like shock? So it is a septic myocarditis shock or it's a distributive shock. If it's a distributive shock with a maintained cardiac contractility, then maybe a double groin cannulation could be a solution. Instead, for a very depressed contractile heart, I think maybe a central ECMO would be better. So we have not enough experience in that, so I cannot give you, let's say, conclusive or supportive evidences in this respect, unfortunately.
Thank you very much for the wonderful talk and joining SWAC also 2023. Thank you very much.
Thank you, and I wish you the rest of the successful, as I am sure, Congress. And again, thank you for the kind and appreciated invitation. Thank you very much.
Thank you.
Thank you, respected speakers and moderators, for this wonderful session.